and management of select pediatric emergencies. It's being presented tonight by Doctors Nikki Austin and Dr. Tammy Bowers. Dr. Austin has been an EMS provider since 1975 and a nurse since 1984. Her areas of specialization have been adult critical care, including cardiac, surgical trauma, and pre-hospital air and ground transport. She has been an EMS provider in multiple states and is an active member of the Pikesville Volunteer Fire Company. Dr. Austin is a Professor Emerita in the Department of Nursing at Towson University. She has led multiple mass casualty exercises with an emphasis in serving pediatric patients. She is certified in emergency nursing, nursing education, and legal nurse consultant. Dr. Bowers has been a nurse since 1987 and has worked with all age groups. She has worked clinically with all age groups for the pediatric patient in the NICU, the PICU, pediatric oncology since 1992. Dr. Bowers has been a clinical assistant professor at Towson University, teaching pediatrics since January of 2015. Dr. Bowers also works with Emeritus Pediatric After Hours Urgent Care Centers. She lives in a rural area in Western Maryland, so she does understand the importance of EMS education and how vital the role of EMS providers are in the pediatric emergencies. She is a certified pediatric nurse and a clinical nurse educator. I thank both of them for coming tonight, and we will proceed.
So hi, everybody. It's good to see at least our names out there. And I want to thank Tammy on somewhat short notice for agreeing to jump on board. We have a lot of fun working together, so I'm glad she's able to jump on and share her piece, nurse practitioner expertise with us. So, so Tammy is going to own the slide presentation. So I'm going to ask her to share. I'm going to do the first couple slides. She'll do some, I'll do some. So if you get bored with one of us, don't worry, the other one will be around. So I don't take credit for the graphics. Tammy is really good at the graphics and I just enjoy them. So next slide, Tammy. So we have a few objectives. We really want to look at the differences between children and adults. Anybody who's ridden with me knows that children really scare me on a call unless they're, awake and alert and happy and there's not much wrong with them. As soon as there's something really wrong with them, I just really want to call ALS and have somebody else take care of them. So, so I always want to take those opportunities to kind of relearn that stuff, relearn and really put into practice the differences between children and adults, and always review the stuff on the ambulance and what's in our bags that can help us with those kids. So we'll talk about the hypovolemic shock, really related to metabolic issues, and not so much. We're not really talking about trauma tonight. So and trauma's, when there's bleeding, it's, we like to fix it. I think metabolic can be a little bit trickier sometimes. We'll talk about the pediatric assessment triangle. So if you're new to EMS, this is, I think, one of the pearls in the MIMS book. I love the pediatric assessment triangle. It can really be helpful to you. So, so if you're new, I hope that this is helpful for you. So we'll look at some assessment. We'll look at some treatment and management, and we have a few case studies at the end. But Tammy, I like to be pretty interactive. If you want to throw questions in the chat and have other case studies at the end that you want to talk about, we're fine with that. So Tammy's going to start, and I'll pick up in a few slides.
So if you can get your phones out, none of this is recorded with your name. It's completely anonymous, but throughout the presentation, I have some QR codes embedded with some questions. So that is somewhat interactive and we can respond with that. You can also utilize the chat. The first one is this one. Tell me something about your role in EMS, and just use a couple of words because Ashley made sure for us, we tested this out. That's why her name is across the screen. But as you scan the QR code and answer the questions, your answers will populate in here. So as you're doing that, hopefully, I want to thank you for the opportunity to present and share a little bit. Dr. Austin was one of my instructors doctors in my master's program. So I am thrilled to be able to present with her and know her as a colleague for many, many years. And she's also an awesome athlete. I've bike rode with her, and she's left me behind and had to wait for me several times. The other thing I thought about, well, we're going to talk about gastrointestinal issues, specifically the metabolic piece with our pediatric patients. And as I was thinking about things, and we all have really good calls and really bad calls, and sometimes it's very frustrating, but one of my most memorable GI situations was in urgent care, and the chief complaint was just vomiting. So I went into the room, and there were siblings in there. There was a 7-month-old and a 15-year-old. And, they both appeared somewhat ill, not super sick at all, talking to them. And so getting information from them. So I said to them, how long have you been vomiting? 2 hours. So it wasn't really an emergency. There wasn't a lot going on. That's not one of the case studies we're going to use in this situation. But we all have those situations where you're kind of glad, like, okay, I can handle this. We can't do anything. Your body has a virus. Let's let it run its course, versus some of the other things where we really do need to intervene, which is what we'll talk about tonight. So we have some responses here: EMTs, paramedics, new provider. And like Nikki said, a lot of people don't like peds. I don't like adults too much. You have too many different cardiac rhythms and stuff. And I don't like that. Fast, slow, or nothing. And that's what I know about cardiac. But we're going to talk about peds. We're going to discuss some differences, because it's really important before we move into the pediatric assessment or anything that you understand that peds are not just little people. So we haven't taken the adult body and kind of squished it down, and we can like divide it by a quarter. And that's, what we do, because there are differences in their anatomy and physiology. So pediatric versus adults, when we're looking at assessment, we should allow the parents to hold them. You don't need to get them on the stretcher. I don't need to have them on the exam table. We don't need to do anything. Approach them with the parents while you're talking to the parents, right up there. Get in their space. Because of our relationship and who we are, we automatically have that intimate space kind of barrier that we can cross when the child is sitting on that parent's lap and we're beginning our assessment. And we're verbally talking to the parent. We're creating that trusting relationship somewhat by playing with the child if we can, if the child is well enough. So allow the parents to hold, and depending on, if you're a larger size person, you're going to be very intimidating to that child. So thinking about those things as we're approaching. So speaking softly, which is really difficult for me, to try to feel out where that child is, because some infants are going to be super interactive with you and open to you. And there's going to be a lot of others that are going to be stranger danger, and depending on what uniform you have on, all those things feed into that increased scaredness of those infants. Toddlers create play. You're doing something, let them play with your badge, let them play with this, let them play with that. They grab something, they're quiet and they're kind of sitting there, so you can do your assessment. Yes, they might be touching your stuff. You might have to clean it off when you're done, but you can get the information you need as you allow them to touch and kind of play with something. Preschoolers want to help. So sometimes that means them helping you place your stethoscope. Where are you putting the stethoscope? In their hands with you. School age, tell them what you're going to do. Help them understand what's going on. Talk to them about being scared. Be truthful. I got to start an IV and it's going to hurt. My general saying with starting IVs in kids is you can scream as loud as you want. I'm going to help you hold your arm still and hold you still. I don't care about how loud you scream, whatever you say, anything, but we're going to help you hold still because we got to get this IV in. So giving them permission to kind of cope in some way while you're starting that painful IV, and it's going to hurt. So telling them it's going to hurt. And in non-EMS mode, we have some things that kind of take away the pain but even the freeze spray hurts. So it's going to hurt. We can tell them it's going to hurt. And then adolescents, privacy is very important. So when we're assessing, we have to be aware of who's around, even in those situations where you're called into the home and, lots of people are around, someone clearing the people out. We do that all the time in the hospital when there's a code. Clear this room out. Who needs to be here? Who doesn't need to be here? Because that all feeds into the chaos. And then across the picture, I put before you assess, undress. Super, super important. Last night I had 8-month-old twins that came in. Mom said, they had a fever at home. They haven't been eating. They have all this congestion. They looked fine. They were playing. But in order to really assess them, I need to look at their chest and their abdomen, see how they're breathing, see what's going on. Look at that abdomen. Is there any ecchymosis? Is there any bruising? Is there any, can you see peristaltic waves? And even in the younger children, how are they breathing? What does it look like? Do you see any obvious math? When we're talking about GI, that one quick look is really, really important. The other piece that we need to talk about in children is that they are vulnerable populations. So we also have that responsibility in that assessment to kind of have our guard up to say, is there something there that doesn't belong? Why is this there? Why is that there? Those type of things related to injuries and abnormalities that we find with those children. So learning more about GI and what's different with kids versus adult, newborns have a lot of fluid. Newborns and infants up to 1 year old have a lot of fluid in their body. It's not all intracellular or extracellular, so their circulating volume does not increase. But there's a lot of fluid and they can dehydrate easier. Higher ratio of extracellular fluid, higher total sodium and chloride. So their electrolyte balance is completely different. And their ability to maintain homeostasis, we might be able to bounce way back. They can only go a little bit because of the fluid, because of the difference in electrolytes, and then the lower amounts of sodium, potassium, and phosphate. They also, I have later in a further side, there's problems with their kidneys created to us. So the rate of fluid exchange is much quicker than an adult. So if they're going to be dehydrated, they're going to dehydrate faster. Metabolism is much higher, which some of us wish we had of those newborns, but things are going to move through quicker and they're going to have less time utilizing the nutrients and the electrolytes than adults do. Acid forms very quickly. They become acidotic quickly. Their kidneys cannot concentrate urine. So one of the big questions we ask in infants is, how many wet diapers have they had today? We expect 6 to 8 wet diapers or soiled diapers in a 24-hour period. When you and I become dehydrated, we're vomiting, we have diarrhea, we will void less. Our body stops getting rid of the fluid. And when you void, your urine is pretty concentrated, full of the toxins that we're getting rid of. For infants, their body cannot concentrate that urine. So they void in the same amount volume that they would if they weren't dehydrated. Their body can't compensate in that way. So again, they dehydrate quicker. Prone to dehydration, acidosis, and then overhydration and fluid overload. So when we're replenishing that fluid, they're also prone to that fluid overload. And this little information here talking about water content, tomatoes, 93% water, watermelons, 92%, cherries, 83%, potatoes, 80%, human babies, 75% water, bananas, 74% water. So they have a lot more fluid than we do. Moving on to toddlers and preschoolers, usually their systems are pretty mature by the time they get to that age, talking about their kidneys, talking about GI, those type of things. And they begin to have that voluntary control of elimination, meaning they're potty trained. Sometimes when we're responding to these emergencies with toddlers and preschoolers, one of the issues we have to look at is, are they incontinent? So I'm moving more into some psychosocial issues that can occur with these toddlers and preschoolers because of incontinence. There's shame and doubt. So thinking about their developmental level, where they are related to that. And depending on the parent or caregivers, there can be negative consequences for that preschooler if they were incontinent of diarrhea. Because they have an immature sphincter control, couldn't make it to the bathroom. So again, always being aware that they are a vulnerable population and what is going on with that vulnerability. School-age children, ages 5 to 12, they can hold more urine in their bladder, so they can go longer without using the restroom. Their heart is smaller in proportion to the rest of their body, so that affects their compensation. Physical maturity does not equate emotional and social maturity. So just because their body systems may be mature, they are not emotionally. And sometimes there are, I want to say, consequences related to that with these children. Again, think about, the child that's in school. And again, we're talking about like a gastroenteritis, vomiting and diarrhea. And it suddenly hits the child and the child is incontinent of diarrhea, and the psychological issues that come along with all of this. So we have another question. Children are more at risk for complications related to dehydration rather than adults. Is that true or false? That's an easy one. There we go. True. Absolutely true. They have more risk factors. They have less of, again, that bounce back from homeostasis. So, sometimes parents or caregivers are like, well, I had it for 3 days and I was fine. And they only had it 1 day and, they're giving you the symptoms. So we do anticipate that they will need more intervention than an adult would with the same disorder. All right. So 13 to 18-year-olds moving on, because they're kind of moving into our adult realm a little bit, maybe not emotionally, but physiologically. One of the things in my world is that in order to receive adult treatments, you need to be 12 years old and over 50 kilos. So a little bit different, a little more stable, sometimes a little more easier for those of you who are used to dealing with adults to take care of a 12 to 18-year-old versus a 5-year-old. Heart rate decreases. Again, their blood volume becomes like an adult. Their blood pressure stabilizes. They can take those deep breaths, so they're not as prone to respiratory issues. Their BMR slows down and becomes more like an adult's BMR, basal metabolism rate. And I just referenced your EMS handbook. And page 10, there's a lot of information about this. I also included your breakdown of your ages for newly born up to 1 hour. Neonate 1 to 28 days is what Marilyn refers to for everyone as a neonate. Some people will say up to 30 days. But for you, and we always talk about NCLEX world, so I guess any exams that you have, 28 days is your cutoff. Infant and toddlers, 28 days to that first birthday. After the first birthday, they're toddlers. 2 years to 4 years, preschoolers. 5 to 12 is school age, and then up to 18 is adolescence, according to Maryland. There are some places that will still treat and kind of take kids up to age 23. So it just, if you're transporting, it may depend on the facility versus their 18th birthday. So what are the risk factors when we're talking about kids and risk factors for dehydration and looking at that hypovolemic shock related to dehydration? Again, that increased basal metabolic rate, their kidneys' inability to concentrate urine, the increased fluid intake of the body. Their heart is unable to change stroke volume. So their heart can increase in speed of contraction. So their heart rate can go up and down, but they can't change the force of the contraction to kind of compensate in any way the way an adult can. So they can't adjust to that decreased fluid volume. And then we also see more electrolyte imbalances like I talked about earlier. So another question, and this is type in kind of your answers, and this will create a word cloud, is why are children more prone to dehydration? We talked about a bunch of different reasons, and I put these in here because these are the things that as a provider walking into a situation should be in the forefront of your mind related to children. Why I'm going to treat this child and think differently when I'm taking care of this child than I will when I'm walking into the same history in an adult. What about this child makes them more at risk to be sicker than an adult? So waiting for responses. I feel like I'm in my classes. I can wait. Lower ability to adapt to that homeostasis. Correct. Anybody else want to answer? Or let me check the chat, which I can't find. So maybe Nikki, you can, here it is.
Somebody said volume.
Yeah, their fluid volume, and they have that decreased compensatory mechanism to be able to kind of conserve fluid. So when they're having that diarrhea or vomiting, their body's not like in that mode that, oh, let's not pee or poop or do anything else that will hold on to the fluid we have. Their body's going to get rid of it. Oh, here's some more. Kidney function. Can't concentrate the urine. And then their inability to adapt. So very, very good. So
Yeah.
we're at Nikki's part.
Yeah, so here's our pediatric assessment triangle, and I think it's really handy for adults as well as kids. Honestly, one of the differences, of course, with adults, especially, is that they can communicate better. They have certainly better verbal skills usually than than infants or young children. But as soon as you walk into that room or wherever you are and you see that child, these are really three things that should get your attention. What does a child look like? Even if you're in the doorway, you're looking at the kid, you're not even holding the kid yet. It's like, what does that appearance look like? Is there something that really gets your attention? Abnormal tone, a child that's not interacting as well as you would expect for whatever that situation might be, unconsolability. And then look at what that child is looking at. We talked before that you might walk in with a uniform, or, we have bags and helmets and all of our other stuff. Do we look scary to the kid? Let's try and minimize that as much as we can. But do you see things in the child's appearance that look abnormal? Work of breathing. When you can hear somebody breathing from the doorway, that's usually not a good thing, right? So we're looking for things like any abnormal sounds when a child is breathing, abnormal position. And can anybody throw into the chat? I don't have any QR codes, but what would abnormal position do you think? Anybody want to get one that we think about all the time? Yeah, tripoding, right? When somebody can't breathe well, they get that tripoding, sitting upright, trying to expand the chest, and that should really get our attention. And retractions, when patients are really trying hard to breathe and they're using accessory muscles to breathe, you might see retractions in the neck, retractions in the chest. You might see flaring of the nostrils. You might see patients who are gasping or maybe not breathing well enough at all. We would call that apnea. But then there's circulation to the skin. I really want to reinforce what Tammy said. You really need to look at the skin to be able to, if a child is wearing clothing and that clothing is covering up the central or part of the body or limbs, you're not going to be able to see them. So please make sure that you are assessing the patient, which means you need to, you need to look at that skin. So pallor is just those patients who look pale to you. I think we all understand cyanosis, that bluish kind of color that none of us really wants to see. But modeling is a little bit different, especially when you're a new EMS provider. If you haven't seen anybody who has any element of circulatory shock, you may not have seen modeling before. We have a little bit of a picture next, so we're going to go to the next slide in a second. Don't do it just yet. But this pediatric triangle is really important. When you walk into the house, you're already thinking about these things, but remember to undress the child. Of course, if it's cold, we want to make sure that they don't get cold. So have a blanket. So if you could go to that next slide, Tammy, that would be great.
I don't even know what happened. Did your screen change?
I'm sorry?
Did your screen change?
No.
Okay,
Well, yeah, it went backwards.
okay, because mine did.
Can you go frontwards?
I'm working on it.
Yep, we're looking at the page that had the QR code on it.
Mm-hmm.
I can
What
share if
page
you need me
function
to
was
share.
it?
I got it. Do you have let me do
Here we
from
go.
the
Yeah,
slide.
yeah, great. So this is a great little addition to the pediatric triangle because this should make you think a little bit, especially if you haven't used this a lot. But if we have somebody who appears normal, circulation's fine, and they're stable, work of breathing, then great, you can move on to your whatever's next on your call, right? But if we look at that area of green, if somebody is really having respiratory distress, we want to think about what we need to do about that. We don't want children to be in respiratory distress. And especially if we're a BLS crew, if somebody's in respiratory distress, we want help for that patient. That may be likely beyond the scope of what we're able to do as BLS providers. So if somebody has the red and the blue, they don't look good and their breathing is bad, we're really worried about respiratory failure. So children can compensate to a bit if anybody's taken PALS. I know a few people have. We think about, respiratory issues as the prime cause for cardiopulmonary arrest in children, infants and children. So we don't want that to happen. So we worry about that. But then if we look at that bottom piece, the circulation in the skin, please undress your kids, take a look at the body, arms, legs, and feet, and see if you think that there is circulatory compromise. Okay, next slide, if we could. Oh, here's another QR code. I didn't do these. Tammy gets all the credit.
Yeah. When approaching a child, the caregiver, what questions do you want to ask them? So you're coming in, you've been called, that you know that the child has some kind of GI illness. What do you want to know? And I know this isn't in the slideshow mode, but it seems to be glitching. It could be my internet here in Hickville or any number of things. So here we go. How long has it been going on? So, and again, we talked about how long has it been going on for a child versus an adult. We're going to have different concerns based upon the age of the child versus an adult. And I keep comparing everything to adults because adults are kind of our, I want to say standard for lack of a better word. And we can look at the deviations from that standard and learn from it. Recent medical history, past medical history. So are there any risk factors? Very, very good. Baseline. Is this what they look like? Are they, so we talk in children about temperament. So if this is a quiet, subdued child, we're going to look at them and their assessment's going to be different than like that child who is very active, very interactive with the world, very interactive with people, and what's their norm, because that will cause different concerns for all of us. Great.
Mm-hmm.
So when we look at it, some of the questions that we want to know, how long has the child been sick? Again, couple of hours for my patients that came in, versus the child has not been able to keep anything down for days and days and days. And the child should look very different if that is very true. When's the last time they had something to drink or eat? And then what was it is another important. When was the last episode of vomiting or diarrhea? I had teenagers the other night. Both of them had a GI bug, and it was Wednesday. And I asked them, I asked the one, when's the last time you had diarrhea or you vomited? Monday night. So, very significant versus if he would have told me he hasn't stopped vomiting since Monday night. How many times? So how many episodes in that 24-hour period? What have you done to treat it? Any number of things could be done. There's so many home remedies out there. And this is where we also have to be careful. And I'm plugging a little bit of I love pharmacology, but there are so many home remedies and so many herbal things and that are promoted that are safe for children because they're all natural. So there are many, many all natural things that can interact with many different things. So we have to ask them about that as well. Anyone else been sick? So that's going to give you an indication of, is this an infectious disease versus maybe they ate something, maybe they have a metabolic illness. So the other consideration I have on here, a lot of times with children, vomiting and diarrhea comes with fever. When we have fever involved, they're more likely to be dehydrated due to insatiable fluid losses. So the losses that happen in their body because their body is trying to cool down that fever. So that sweating, that evaporation of fluid, those all are losses of fluid for that child that younger children have a lot of trouble replenishing. So go ahead.
Tammy, I'm gonna jump in here about the issue about, is anybody else sick? And I know Chief Nats, I put that question in or that answer in there. So I really want everybody to go back and think back to that scene safety piece. If anybody else is sick in the house, if we think that there's an infectious disease, please think and get out things like the gowns that we carry. You want to also ask if the child's been on antibiotic therapy for some reason, and perhaps the child has C. diff, is there what do the stools look like? Are they watery, bloody, all that sort of stuff, because you don't want to catch this if it's an infectious agent. If you're not sure, you're much better off doing what we just call contact isolation. You don't want to touch it. I know we've all been on calls where somebody has diarrhea and then there's no diarrhea during the call, or maybe there's a lot, right? Or you're covered with it. Anybody been covered with it? So make sure that if you have any index of suspicion, get out the gowns, use your contact isolation. Don't take it home to your station or to your family, right? If you have multiple people who are sick and they only want to give you one, you need to look around a little bit. And if there are multiple patients, do you have the resources to care for multiple sick patients, especially if they're kids? I'm going to call for help if I think that we need help. So just think about those things. Think about that scene safety, body substance isolation, and don't get yourself all covered with, bad body fluid. Okay, thanks, Kenny.
Good, very good point, because for me, I accepted that when I thought about those I love more than myself. We're all used to running in there, taking care of what we need to do, but then thinking about the ripple effects of, I'm going to bring this home to my kids, to my family. And for me, that was like my, why for isolation. So to find your kind of why of, why do you need to protect yourself versus I can do this, I'm healthy, I'm good, all that kind of stuff, because we all do it. So earlier, Nikki talked about some things that we're looking for in our child. A lot of this we can see as we're approaching the child or we're asking those questions that we were talking about. So we've been called, we have a child of 0 to 18, any of those ages, and we're going to do our assessment and what do we really want to look for in those kids. So the first thing is level of consciousness. If you go in and that infant or that child is just kind of, really need to investigate that. Again, I said temperament, but that child should not be just kind of hanging out there. You can do whatever you want. Yeah, you can listen to this. I'm not asking any questions. I'm not concerned. You know, kind of, I'm going to use the word laissez-faire, for lack of a better word. They're listless in some ways. That's not a normal childhood reaction to a stranger coming into their personal space and touching them. So that's a big red flag right there, that they are tired out. So they're fatigued, maybe irritability. Irritability in a child can indicate they're in pain. It can indicate that they're exhausted. There's so many things that can indicate. So being aware of that, again, the lethargy, and then of course, unconsciousness. Breathing, is their breathing fast, normal? Are they breathing deep? Are they, someone put in the chat when Nikki asked the question about grunting. In kids, grunting, that expiratory grunt is major. So when you have that with every breath, or even not every breath, grunting is huge for kids. So what does that look like, and what else is going on, as Nikki talked about with that respiratory distress, looking at nasal flaring, circumoral cyanosis, the retractions, abdominal breathing. What does their belly look like? Is it seesawing? All those type of things. Their extremities, are they warm? Are they cool? Are they mottled? Are they cyanotic? So that's a picture of mottling. To me, it looks like uncooked sausage, like the texture, like you can see that in there. On very young children, some models, like neonates, some modeling is normal. So we expect that, especially when you open them up and it's a little chilly. But this child, that modeling is everywhere, and it's pretty pronounced. That's significant for this child. So we're looking for that. The cyanosis. So in newly born and neonates, we have some acrocyanosis, which means their hands and their feet become cyanotic because they have poor circulation. So that's somewhat of a normal finding. But if you have a school-age child who has some cyanosis in their extremities and they're cool to touch, that's a big red flag on there. So their eyes, do they look sick? And usually the eyes kind of tell the story of children looking sick. Are they sunken in? Are they deeply sunken in? Do they have dark circles? Do they have some kind of bloodshot in their eyes? What does the conjunctiva look like? All those things give you a picture of how sick the child really is. Heart rate in kids, like I said, fast, slow, or nothing. Do you want to say something, Nick?
No, you're good. Thank you.
Mouth and tongue, what's it look like? Are their lips all dry and cracked? Do they have cracks at the corner of their mouth? What's their tongue look like? Because their tongue can also get dry. The quality of the pulses, what are they like? We do expect, again, neonates and younger infants, for some of their distal pulses to be weaker. But what are they like? Is that normal for that age of the child or not? Are they weak? Are they thready? Can you not palpate them at all in those child? Do they have tears? If they're crying, are they producing tears? Their thirst. So most of us have heard the story of Josie King. If not, I invite you to look it up. There's a great video that our mom talks about. This child was admitted and there were several issues that occurred, but this child was in the hospital sucking on the washcloth as she was getting washed up. She was so dehydrated and thirsty. So does the child want to drink? Do they not want to drink? So those things give us a picture in there. And generally speaking, children should drink pediatric replenishing electrolyte solutions. And that is I'm going to use the word theoretical answer for replenishing. But generally speaking, when children want something to drink and they're dehydrated, what do you want? When they're willing to drink something, it's going to be whatever they want. The Pedialyte and those kind of things are the best thing for them in that situation to replenish them, but it's that will thing. And then their urine. Is it normal? Is it decreased? Or is it minimal urine at all? How much are they voiding? And then even examining, like, if the child has a diaper on, opening up that diaper, what does the urine look like? You know, I had a child come in last night, 3 months old, mom telling me she was listless at daycare. She just hasn't been herself. I think it's a viral illness. She's not nursing like she should, this and that. How many wet diapers did she have at daycare today? So she had 4 wet diapers at daycare. That was about 8 hours. So when I think about that in the scope of 24 hours and 6 to 8 wet diapers in a day, it's pretty good. I go to examine the child and she's got a saturated wet diaper. So that's telling me a lot about this child's hydration status, because the child was playful and a lot like kind of normal assessment, that what the mom was telling me wasn't lining up with what I was seeing with this child. Next, we're going to go back to your handbook and talk about what your protocols say and what you need to do. So when we're talking about nausea and vomiting for BLS, the protocol is the same as the adult protocol. Nothing new you need to do. Honestly, anytime you come to nausea and vomiting, you should kind of consider it infectious, unless even the patient on chemotherapy and those kind of things, nausea and vomiting, it's body fluids. So you can move from there, but we're going to put the patient in the position of comfort. And we're going to allow, if they're kind of passing out and feel really nauseous, they can inhale the vapor from an alcohol wipe. For children, dehydration of at least 5% is if the child has 2 or more of these signs. So if they look sick, you walk in, they look sick. You're like, oh, yeah, this child's sick. Capillary refill, greater than 2 seconds. Absence of tears and dry mucous membrane. So any 2 of those, your child's already down 5% of their body fluid. Moving on to ALS.
Can I jump back
sure.
there for 1 second?
Yeah.
Because I always tell my students this. So capillary refill, you know, there's this number of 2 seconds, right? So we all know that there's situations where, you know, like cold, for example, where capillary refill might be altered a little bit, but make sure you actually make note. And if somebody's capillary refill is 4 seconds, write 4 seconds in your documentation. You want to be absolutely clear. If I'm calling the hospital and say capillary refill greater than 2 seconds, you know, I'm the nurse on the other end of the phone, and I'm like, yeah, what does that mean? Because I think that you would all agree a capillary refill of 3 is greater than 2, but capillary refill of 6 is much worse than a capillary refill of 3. So we really want to know, we really want you to count, and you really need to put that in your documentation, because it helps us really document. It gives a lot of extra information about how sick that child is. And of course, you know that if capillary refill is bad, your pulse ox may not work, and then you have all kinds of other issues. Please identify quickly if you need extra help with this child. That's it. Thank you.
So let's see, we were here, right?
Yep.
So moving on to ALS, we're going to move into some interventions. So that child was sick. We need more interventions. What are we going to do? Of course, we know in this situation with vomiting and nausea and perhaps diarrhea that our child is going to be fluid depleted. So we're going to need to replenish that fluid. Establish your IV access. Of course, lactated ringers is going to be our replenishment fluid, 20 mLs of fluid per kilogram. And I just wanted to take a time out there to remind you that you can use your, I still call it Broslow tape, at that point to determine the weight of that child. If you don't have an accurate weight from a parent or a caregiver, don't hesitate to use that Broslow tape, because using the Broslow tape is protecting you as well, versus that kind of guess that you all just agree and let's add up what we think it is and divide it by the number of people we are and get the average of how much we think this child weighs. So you're protected in that Broslow tape. So using that child's weight, and then looking at their blood pressure 2 times the patient's age in years plus 70. So is their blood pressure normal, or are they moving into that shock that we were talking about earlier, that hypovolemic shock? We can move into meds. There's one med that is recommended on Dancitron, and there are considerations for giving that, and we'll talk a little bit about that. So under 28 days, you cannot give that medication. And then 28 days to 12 years is 0.1 milligrams, and then 13 to 18 is 8 milligrams, and you can repeat it times 1. So the other thing I have on here, and mine is covered by the pictures, so I didn't say this first. I have the transformer, whatever this is, picture there, because the way that I learned this medication and how to say it, and Ashley, I was smiling when you said it earlier. I don't know how to say that medication name, is treat it like it is a transformer, like Robotron, all those. So Ondansetron is our transformer medication that transforms nausea and vomiting into a well patient. So just a little, those of you who are transformer geeks and understand all that, a little something for you to remember that and help.
Tammy, Sarah has a question in the chat. She
Okay.
asks if we have reasons to suspect dehydration, but they are normotensive, can we still administer fluids? So I would say if you think that they're dehydrated, especially in a child, you want to give a little bit of extra fluid before that child starts becoming hypotensive. I don't want a hypotensive kid. So would you agree?
I would say it depends on, and this is horrible, I think there's a lot of depends on that one because of the fluid overload issue. But honestly, one fluid bolus probably not going to do very much if they are not to cause any really negative problems. So the big point that like you learn in PALS and everything, if they respond to the fluid bolus or if they don't, it's okay to give that other one. So looking at giving that fluid bolus, yes. And then what do they look like afterwards? So did you get a little jump in the blood pressure, even though they're not what we would classify theoretically as hypotensive? Did the blood pressure go up any? Did the child, like, is the child more alert and interacting with you a little bit? Like all those pieces tell you about the effectiveness of this. The only concern, again, is that fluid overload, which is, I'm going to say rare, unless you're doing multiple boluses without that blood pressure and the other signs. So yes, err on the side of caution and give them the fluid bolus because, as Nikki said, kids crash quick. So a little bit of extra fluid, they're going to pee it out and it's going to be fine. Did that answer?
Yeah, thank you.
Okay. So moving back to Ondansetron, you can give a third dose with medical consultation. The problem with the third dose is it can lengthen PR intervals. It can cause that prolongation. And there are a lot of people who don't even know they have this. Kids never get EKGs, that kind of thing. So there is risk in giving that third dose. However, with that consultation and seeing improvement in that child, there's multiple things that would indicate, yes, let's give a third dose of this medication. So if you do give that third dose of Ondansetron, you need to make sure that child is on a monitor and that you're looking at that monitor. I don't know what's going on with we did a part of this. Okay. What is the risk when giving high doses of Ondansetron to the child? Which, if you scan this QR code, it's going to give you a multiple choice question. So this was us playing with it. I didn't reset it. So if you scan it and you do the answer, it will change this. There we go. It's the prolonged QT interval is the correct answer to that. So again, keep that in mind. Giving that higher dose or extra dose of that Zofran or ondansetron, they need to be monitored. So this is all from your handbook. So what we give ondansetron for is antiemetic and anti-nausea. And the other question with this that you really need to look at before you give it is to ask them, we talked about what have you done to treat this? And specifically ask them if they've given the patient any of this, because there are many providers who will prescribe Zofran or ondansetron, and people will have some left over from the last time they were sick. So again, that QT interval or that we're looking at is very, very important. So you want to know if they have any on board already, because if they do, then, and you given that first dose is going to be that higher dose, and it can affect them. So onset of action, 15 minutes for IV, 5 to 15 minutes, very quickly. IM, 30 minutes. It prevents or controls nausea for a lot of patients. Some patients it doesn't work at all for. Can be given if nausea and vomiting can complicate an injury. So thinking about if the example that your book gives is that eye injury, and the vomiting, that pressure is going to make things worse. So I included that because it's just education about this particular medication that is good to have. Contraindications, very simple allergies, and then that neonate. It can cause hypotension, tachycardia, EPS symptoms, seizures, and then that QT interval prolongation. And so we want to monitor that EKG, and we should also be ready with this with our emesis bags. And here are your specific indications and dosage for this. So again, it comes in PO, and a lot of patients have this in their home. So to make sure they haven't given it. Next, moving into shock. So the kid's getting worse. So we're just kind of going up the worsening scenario situation. What happens? They're hypovolemic. They don't have enough blood flow to meet the oxygenation demands of their body because of that decreased fluid volume for these kids. What does that look like? Change in mental status. Again, that lethargy, that the kids are listless. The kids are not interacting. They're not fighting you. They're not scared of you. Cold, clammy skin, diaphoresis. Fast heart rate, weak pulses. So that heart is trying to compensate in these kids. And it's beating faster to try to get more perfusion. Weak pulses. So it's beating faster, but not more effectively. Shallow labor respirations. Again, that capillary refill that Nikki talked about. Decreasing pulse pressure, and then that blood pressure is going to start dropping. So looking at our shock protocol in adults and kids, it's the same. Place the patient in a supine position with the legs elevated. We're trying to promote that central circulation and get all the oxygenation that we can to that centrally. Closely monitor the airway. And then there's a pregnancy, 20 weeks with hypotension, left uteral. Anytime in pregnancy, if there's a question of anything, that left side is the way you roll them. And then moving on to our ALS, when we talk about that hypovolemic hypoperfusion, we're going to get IV access and we're going to get fluids. Again, that 20 mLs per kilogram, IV or IO. Volume sensitive children, there are lots of chronic kids out there now, so we have to be aware of this. We're going to include those neonates, okay, so they can't regulate that fluid, congenital heart disease, chronic lung disease, or chronic renal failure. Those are considered for your protocols. Those are volume sensitive kids. 15 years older, and that's for hemorrhagic shock, so we're not even going to talk about that, but that's all part of your protocol, and you can look at that. I'm going to skip this because it's long. Shock and hypoperfusion. here is your protocol related to that. So then you can move into your medications. When that child is not responding to that fluid bolus, give another fluid bolus. When you know that child is hypovolemic, they haven't responded to the first one, give the second one. And then you can start moving into, with medical consultation, your pediatric epinephrine. And then here, again, your blood pressure goals. You want to normalize that blood pressure. You want that level of consciousness to come back to where it needs to be for that child. And these are your, again, 70 plus 2 times the year in age for that child. The other thing we need to talk about for this situation is moving through. You can't get the IV access in. You can always do interosseous. Interosseous is used for cardiac arrest, profound hypovolemia, no access, 2 unsuccessful peripheral IV attempts, and peds and cardiac arrest with no obvious peripheral IV sites, which is usually the case. Reviewing what you need for interosseous infusions, there are multiple sites and different size and gauges for different ages. Questions? Let me just look in the chat to make sure anybody want to chime in with any questions. We're going to move into case studies after this. So we'll need you to kind of either communicate, turn your microphone on and communicate, or communicating in the chat to talk about the case study. So I don't see any questions. So we'll move to the first case study.
Okay, so you're a BLS student. You're dispatched for a sick child. You know, we get those sick person calls all the time. You arrive to find an 11-month-old with a history of vomiting and diarrhea for 24 hours. Your assessment: the child is pale. The capillary refill is 4 seconds. AVPU, which patient responds to your voice. What would you expect? We always want people to be awake on alert, right? This child is not, and responds only to voice. Heart rate is 142, respiratory rate is 30, BP 80/52, SpO2 is 89%, and temp is 102. What else do you want to know? Feel free to jump on board, unmute, and let us know. How are you?
Temperature.
Temperature. Okay, temperature is 102.
Positive test like COVID.
Okay. Anything else?
How long?
How long has the child been sick? So the parent or guardian tells you a history of vomiting and diarrhea for 24 hours, right? Any history of current illness and past medical history. Glucose, we absolutely want a glucose on the child, right? Anything else anybody wants to chime in? Yep. How long? It's been 24 hours. It's a long time for a kid, right? And so is the child sick or well? If I looked at this child and I saw capillary refill, yes, is the child eaten? And I have this assessment criteria in a child. I think this kid is sick. Wouldn't you agree? I think this kid is sick. If I'm a BLS unit, I want help with this kid. So I'm gonna request some ALS and see if there's any ALS around. But I think this kid is sick, and I would be worried at this point. That heart rate is high, the respiratory rate is high, blood pressure is low, that capillary refill time of 4 seconds is too high. So I'm definitely going to document that. So we also, kid is sick, right? We're thinking back to that pediatric assessment scale. The respiratory rate is high, capillary refill is too high, pulse ox is not good. So the child needs, anybody remember that protocol? How much oxygen percent does that kid need? This is your MIMS protocol quiz. This child needs 100% oxygen, so a nasal cannula is not going to cut it. We want to get that SpO2 better than 89. So we're going to start with that 100%. And if the child needs assisted ventilations, please think about that. A respiratory rate of 30, please take your stethoscope. You're going to undress that child and you're going to listen to those breath sounds front, all the way in the front, and you're listening to breath sounds in the back. But that child needs some oxygenation, and we're going to call ALS and go from there. We absolutely want to know about other patients in the house. If there's vomiting and diarrhea, please gown up for this patient. And what priority do you think this patient would be? If you think this patient is sick, you're going to call the hospital. Please, you're going to call the hospital and say, we have a sick kid. We think this is a priority. I think this could be a priority 1 patient. There are too many things wrong with this patient, right? We don't want to under triage this patient. So what would be our treatment? It would be appropriate for this child to have that oxygenation, right? We haven't talked about warmth, but don't let these kids get cold. We need blanket. I know the temp is 102, but especially if you have air conditioning or whatever, just don't let the kid get cold, right? So we're going to treat, we're going to give oxygen. If we have IV, we're going to do that, and we're going to transport that kid quickly into the hospital. Does anybody have, yeah, IV access for sure. Remember 2 IV sticks, and we need to move on to IO, but we need help with this kid if we're BLS, for sure. So we can take in a parent with us, a parent or guardian, right? Because this child is only 11 months old, so we need somebody else, hopefully with us for that child. So let's go ahead to the next one. Okay, so we have case study number 2. Summer's coming, so this is our summer 1. EMS is dispatched for 15-30 hours for an unresponsive child on a school athletic field. If that's, we're always thinking, well, kid got injured or something on the child on the field, but we just don't know till we're there, right? The temperature is 90 degrees for the 4th day in a row, and the child is on a soccer team, been playing soccer for an hour in 90-degree heat. Staff reports that she passed out for a few minutes while she was running. There's no contact other than the ground, and there are no apparent physical injuries. So your assessment is capillary refill time of 3 seconds. Are you worried? Well, that's going to get my attention. Half poo is another verbal. That's going to get my attention for sure. Heart rate is a little high. This is not an infant. This is a 12-year-old female, so more adult-like, right? A respiratory rate and the blood pressure is a little bit on the low side. SpO2 is 93, so I'm not worried about that so much, and the glucose is 90. No sign of trauma. Patient denies pain, is able to move all extremities. What else would you like to know?
You see this, has she been eating and hydrating?
Yeah, exactly, right? Has the child been eating or hydrating? And so my answer to that would be the child had breakfast and has had no food since breakfast. And the child does not report any appreciable amount of fluid intake. And you look around and there's no water on the athletic field, and it's 90 degrees. Does that concern you?
The other thing that this 12-year-old brings into play is this 12-year-old can be 40 kilos, or this 12-year-old can be 110 kilos. So I see the history of diabetes, like all those kind of things. 12-year-old, it's a big window and a lot of differences.
Mm-hmm. Right, so you're gonna do some extra assessment. We all want to know about the diet. Diabetes, was the skin sweaty or is the skin dry? I didn't put in here whether the skin was pale. It could be a heat emergency, right? So is it possible to get some hydration? Oh, last menstrual period, that's a good one.
Yeah.
So what's your plan for this patient? So if you're BLS, do you want to load and go? Do you need IV? So there are a lot of things wrong, right? Or there are a lot of things that it could be. So if you're not sure about any of that and you feel like you need ALS for this patient, it's time to go, right? Cool, absolutely. IV, EKG, fluids. And so is this an ALS patient or a BLS patient? I'm not sure about any of these things. You're right. I'm going to want ALS because You know, we need that IV access, and there are too many other unknowns about this patient. And what's your priority for this? Oh, Chief Nats, do you have an also? So definitely, so she could certainly be a priority 1 patient, and we don't want to hang around for a long time. Priority 1, priority 2, you know, depending on, you know, do we have any more information at the scene for sure. Okay, let's talk about the next slide, the next case study.
So we are dispatched to a school for a 7-year-old male who passed out for a few minutes and is now conscious but confused. No medical history. The child is sitting with his legs drawn up to his chest, arms wrapped around the legs and rocking. The child looks small for age and withdrawn. Clothes are dirty. Initially, the child refuses to let EMS touch or approach him. How would you approach the child? Have trauma in there? Yes. Thinking there could be some kind of trauma. What kind of trauma are you thinking? Physical. So what about this passed out there he's okay sitting in a corner now. Has he eaten? Right. So did he pass out because of low blood glucose? So someone would sit at his level, could be physically or sexually abused, malnourished, and food being withheld. Does he have abdominal pain? Beautiful. Yeah. Did he have a seizure? There's all kinds of seizures. Bruises. Are there bruises anywhere? Absolutely. Guarding his stomach or her stomach, head and neck trauma. So we have capillary refill is 3 seconds. I had to look up. How do you say it, Nikki? Because we don't use that.
ABCU?
Yeah.
Yeah, that's in our health assessment book, Tammy. Is a child
I looked it all up.
Responding in alert, or verbal, responding to
Right.
pain, or unresponsive.
Right. So we have, I just read in the chat that someone wrote, get a trusted teacher. You know, we're talking again, looking at that big picture of a child versus an adult. Even an adult like this, you need to build some kind of trust. Heart rate 110 is normal. 110 for us is normal. Heart rate 110 for a 7-year-old. Respiratory rate 24, BP 90/76, pulse ox 93, glucose 90, no signs of trauma. The patient denies any pain, able to move all extremities. What is your plan? Check for head trauma, get down on their level. Special needs. Is this normal behavior for this patient? If the child wasn't special needs, and this could be normal behavior, but like this is something that is, I'm going to say, concerning to involve more investigation. Like the child is withdrawn. The child is sitting there, like kind of pulling into himself, indicates it could be some kind of, again, abuse or trauma with that patient. So that's where more information needs to be obtained related to their assessment. So again, undressing, getting other people out of there. And then it's not normal, even with the previous slide and case study, it's not normal for a child to pass out. They don't get orthostatic hypotension like adults, you know? So when a child passes out or loses consciousness, that's a big red flag. Build rapport, gather information, you know, history from school, his temp, EKG, do they have anything at all on this child? Malnutrition. You know, that's a great one. And over time, if this child is malnourished, he's small, like all these other pieces we have, if he was in phys ed class, he might not be able to just run. That could be enough to just exhaust him. So a lot of factors to kind of put in there and to think about when children are malnourished, abused, they protect their environment, they protect the world that they know. So they are not necessarily going to fully disclose immediately, oh yeah, I haven't eaten for 8 days. You know, that's of course exaggerating, but so with kids, one of the things that I've learned is that you have to specifically ask them about what did you have for breakfast today? Not what you usually eat for breakfast, like all those kind of pieces. So giving them a concrete place where they can go and obtain information. So this is definitely a CPS call, the clothes, like there's so many pieces that kind of factor into that. And sometimes it's really frustrating to get CPS involved. I've had great social workers that like really listen to what I'm saying and these things, and I've been blown off as well by CPS. My coping mechanism personally is that I have my box where I have to work in and I have influence. So when I hand that case off to CPS, I have to let it go, that I've done all within my power to give it to them. So that sometimes it does involve follow-up and those kind of things, but like I did all that I can because we have to also keep us healthy. Not worried later about things. So great job on this. Any questions for us? I'm going to stop sharing.
So I'm just going to make a quick comment while everybody's thinking about questions, and that's it. We didn't talk about adverse drug, bad drugs in schools. These were two of these were events in the school or whatever. So, but we didn't talk, like maybe did somebody slip a gummy bear to this child and now the child is not acting quite right. So those are kind of tactful questions, and if so, or you're not sure where to come from, those are all kind of different questions. But
or even did the child find gummies at home and bring them to school because they thought they were candy?
Yeah.
There's so many pieces to that.
So if anybody have any cases you wanted to share, you want to talk about, or any other questions, this would be the time. We think. Go ahead.
Yeah, no, thank you so much. One of the things that came to my mind, interesting, and you kind of brought it out, children are not small adults, but eventually they become. So for you, when does a child become an adult? I mean, I've been told two things. Some places will use absolutes such as age. They're 18, others use 14. And then on the other side, I've heard weight, 40 kilos or 88 pounds. I mean, there's nothing that's 100%, but what do you guys go by for this?
The literature that I was always taught with is that, well, to look at protocols as far as like meds, for instance, 12 years of age and 50 kilos. Now, I can tell you that there are plenty of times where I'm prescribing like amoxicillin for a child, and I do it weight-based, and I get this message from the computer that says that is more than the maximum daily amount. So I feel like things kind of change related to obesity in our society. Legally, in the state of Maryland, at 18, or if they're emancipated in any way, they're an adult. So I feel like there's not, your protocol says 18 is still, 17 and 364 days is a child. So, like, I feel like you have to look at your guidelines to be able to truly define that.
Yeah, there's no right answer, and you get we'll be in the trauma bay. You get the unconscious patient who comes in, and you look at him, and you think, oh, it's a young adult, and then all of a sudden it comes back, they're 16, and then you have to change teams because of policies, and now you got the pediatric trauma surgeon, not the adult trauma surgeon, on this 220-pound child.
Well, and that's
6 foot tall.
The 12-year-old that Nikki was talking about, the same thing. I've had 12-year-olds that are, I've had 5-year-olds that are over 100 pounds, so we then, in Nikki's like medical situation, you then have to like, are they really diabetic? Do they have hypertension? What, could it be a stroke because their cholesterol is elevated? Like there's so many pieces that are starting to come into play with these variations that we see. And like you said, there are no clear lines as far as, like you said, you think a 12-year-old can look like an adult.
Yeah.
And you're like, oh my God, we thought, you know, and then you're like, have to change everything. I agree.
And then the one other part, if any time and you're in the field, you ever suspect abuse, you need to report it. Let the professionals figure it out later. You're not going to get in trouble for an honest report. And you want to report it and you want it to be figured out. And if it's not, great. But if it is, you could have saved a life.
Yeah, there's so many, like, and like I said, I've been treated well and I've been treated horrible, but my compensatory mechanism is I saw this, my red flags went off, and it's not right. So I'm going to do what's within my power to do. And again, don't let anyone else influence to say, no, I'm not going to report this because whatever. If your red flags are going off, you need to report it.
Right. In the pre-hospital environment, you will see things that they just don't see at the hospital. And that's okay. And if there is a suspicion, just raise it. It'll be figured out later. But if you have a suspicion, report it.
The other
Okay.
thing that I document frequently is if I smell marijuana. Just because I want that in the medical record, and I'll say to them, I smell marijuana. I've said it I call it the MJ. Smell the MJ in here, you know, and they all like start giggling or whatever. But like some rooms, I mean, it permeates the whole hall. So like that's something as well. That child's been exposed to that, you know. That just, you know, that's part of your assessment, that scene that you're documenting.
I've seen too many over the years pediatric cardiac arrests from drug overdoses where they ate somebody's gummies or whatever that was laced with whatever. And I've seen several deaths from it, and it's out there. It's sad. It's heartbreaking,
Or the
but it
kids that
happens.
get into the methadone, the locked methadone boxes, you know, that the parents are in the program and they are able to get a couple of doses. We've had several of those up here recently.
And abuse comes in many forms. And somebody had written in the comments about malnutrition, and that is a form of abuse.
Well, thank you all for participating. It's been our pleasure to share some time and space with you. Thank you, Jeff, for moderating.
Thank you for coming. It's always good to see you, and I'll see you at the station too.
Yeah, okay.
You come back.
Yeah, take care.
The next conference will be Dr. Marcy Feynman talking about ultrasound influence of decision making for the trauma patient. That will be coming out. We'll send out the formal announcement via the email. And otherwise, thank you everybody for participating. Hope to see you again.